Ladies and gentlemen, now we start the next session, chaired by Yosuke Nakai, Kazuo Hara, Cosmas R. Lesmana. Please start the session.
Good evening, dear colleagues, ladies and gentlemen. So now we are in the Biliary 4 session about tips and tricks in endohepatology with EUS, endoscopic ultrasound. So I will be co-chair with Professor Nakai and Professor Hara. So the first keynote lecture, so it's the state-of-the-art of endohepatology, will be delivered by Professor Yosuke Nakai from Tokyo, Japan. So I think he's very famous, so no need introduction. Please, Professor Nakai.
Thank you for a nice introduction. So first of all, I'd like to thank Professor Isayama and also Professor Sina. He's the president of this conference to invite me in this session. So I will talk about state of the art of endohepatology. There's no COI. So endohepatology is a new term. When I was in the UC Irvine with Professor Ken Chan, we had a research meeting to make this book. This is Gastrointestinal Endoscopy Clinics of North America. It was published in 2012, and I went to UC Irvine around 2010. And we had a research meeting, and we talked about what kind of topics we should select. And in that research meeting, he said we should make this publication, endohepatology, a new paradigm. I think at that time, just liver biopsy was available, but he foreseen the future of this field. And he defined the endohepatology as the integration of endoscopy within the practice of hepatology. And this is a picture he put in that article. As I mentioned before, there was a liver biopsy at that time, but he also think about elastography and EUS guided portal system shunt. And also at that point, he mentioned about portal pressure gradient measurement. So now we have new devices or procedures in this field of endohepatology. So endohepatology means endoscopy and hepatology. So previously, we use EGD scope to evaluate and treat varices and also portal hypertensive gastropathy. And we use ultrasound to perform elastography and attenuation for fatty liver and also liver biopsy, paracentesis, and the tumor ablation like RFA or ethanol injection. And the radiologists perform portal pressure gradient measurement and also liver biopsy or TIPS. So now we can do this using a EUS as a one-stop clinic. So there are two indications for endohepatology, parenchymal disease like a chronic liver diseases or focal lesion like liver tumors. So we can perform ablation or injection for focal lesion, and we can perform biopsy or elastography for parenchymal diseases. So first, I will talk about EUS-guided liver biopsy. I think it's common outside Japan, but in Japan, most hepatologists still prefers percutaneous biopsy because sometimes the specimen of the EUS-guided liver biopsy is fragmented. So these are the studies for EUS-guided liver biopsy. What is the best needle types for liver biopsy and the EUS guidance? This is a comparison of 19-gauge Francine needle and the conventional FNA needles. And if you use the Francine needle, there are longer specimen with more portal tract, like this specimen. And if you compare two kinds of FNB needle, Francine needle and fork tip needle, with the Francine needle, they get better accuracy with longer specimen and more portal tract. And what is the best needle size? We usually use a 22 gauge needle for conventional EUS guided tissue acquisition, but for liver biopsy, we should choose a 19 gauge needle to get a longer specimen and a more portal tract. And the suction method is also under debate. We can use a wet suction or dry heparinized suction. And in this trial, if you use a wet suction, they get more specimen and more portal tract. So I think right now, 19 gauge Francine needle with wet suction is the current standard technique for EUS guided liver biopsy. And how do we compare EUS guided percutaneous liver biopsy? In the meta-analysis, there is no significant difference if you compare EUS and the percutaneous liver biopsy. But in this small randomized control trial from the Biliary group, they see some difference. So if you perform percutaneous liver biopsy, you have a longer specimen. So, and the optimal specimen in the liver, percutaneous liver biopsy. So they recommend still percutaneous liver biopsy rather than EUS guided biopsy. So there's still some debate. And I will talk about liver stiffness measurement next. Historically, we use fibroscan to measure liver stiffness, and we all know higher liver stiffness means a higher risk of HCC development and liver failure or mortality. And now we have a EUS guided shear wave elastography, so we can measure liver stiffness under EUS guidance. And this is a comparison of percutaneous VCT technique and the EUS guided shear wave elastography. So overall, still percutaneous elastography is better than EUS guided shear wave elastography, but they mentioned in the obese patient, it's difficult to measure liver stiffness percutaneously. So they recommend EUS guided elastography in those patients with obese and have a muscle D. I think this is a very unique study. When we were residents, we learned palpitation of liver, but now we don't do that. But with the EUS, we can do that under EUS guidance. So if you use the up angle of the EUS scope, if the liver is softer, there's an indentation by the probe. But like this case, it's a fibrosis stage 4. It's too stiff to push and make an indentation of the EUS, by the EUS probe. So you can measure liver stiffness just pushing the liver using a EUS probe. So it's a very cheap method to measure liver stiffness. So I think this is a very popular technique for EUS guided liver evaluation, EUS guided portal pressure gradient measurement. So with this needle, it's a 25 gauge needle with a pressure measurement device. At the end of the FNA needle, you can puncture portal vein, and also you can puncture hepatic vein, and then measure EUS guided portal pressure gradient measurement. By measuring this gradient, you can make a correlation between the clinical outcome, like high-risk cirrhosis or risk of varices and portal hypertensive gastropathy. And this is the first human trial. There are so many trials after this pilot study. And this is a recent study. They perform a simultaneous EUS guided portal pressure gradient measurement, also they perform EUS guided liver biopsy. Interestingly, there are no good correlation between the portal systemic pressure gradient, which means the EUS guided PPGM, and also fibrosis on the histology EUS guided liver biopsy. However, they found EUS PPGM results correlated with percutaneous elastography. So still, we are not sure what is the gold standard to measure portal hypertension and its clinical outcomes. And this is another interesting topic. I put EUS guided tips, but I think it's inaccurate because tips means transjugular portal systemic shunt. So these are the still just animal study with the pigs. So you can put a metallic stent between the hepatic vein and the portal vein and the EUS and the fluoroscopic guidance. And in this study, they use a lumen posing metal stent for portal systemic shunt. So maybe in the future, we can use this technique rather than tips. Because if we perform EUS, we can do everything under EUS guidance. And this is also the hot topic for endohepatology EUS guided vascular interventions, especially in gastric varices. So we can puncture gastric varices and put a coil or CYA to eradicate gastric varices. So this is, I think this is also hot topics. There are so many studies, but there are no comparative studies, so we are not sure this is the best method, or maybe we can use another technique. And this is published in 2022. They did a gastric varices eradication under EUS guidance using a coil, and they also perform coiling in the splenic artery. So with this combined technique, they can eradicate esophageal and gastric varices and also increase platelet number. So maybe this is another indication of endohepatology. For liver tumors, we all know contrast enhanced harmonic EUS is good for detection of small liver lesion, especially in the liver metastasis from like a pancreatic cancer. So with a B mode, sometimes it's difficult to detect small lesion, but if you use a contrast enhanced harmonic EUS, we can easily detect these small lesions in the parenchymal phase. And then we can perform EUS guided biopsy, especially in these deep lesions from the percutaneous. Sometimes it's difficult to puncture under trans-abdominal ultrasound. So these are the good indication for EUS guided liver tumor biopsy. And if we can take a biopsy under EUS guidance, then maybe we can perform ablation. So this is ethanol ablation under EUS guided EUS guidance using ethanol for hepatocellular carcinoma, and we can also apply RFA in combination with contrast enhanced EUS. So these are the maybe future indication for endohepatology. And as I mentioned, EUS guided PPGM, portal pressure gradient measurement, is spreading worldwide. And if we can measure pressure, then maybe we can sample or we can inject something to treat cancer. So this is a EUS guided portal vein sampling of circulating tumor cells. If you compare with the plasma circulating tumor cells, there are so many cancer cells in the portal vein in patients with like a pancreatic cancer. So we can get a good specimen for like a genome analysis or something, if you puncture portal vein, or like patient with liver tumors, we can inject chemotherapy drugs to manage these liver metastases. So this is the first concept of endohepatology proposed by Professor Ken Chan in 2012. First, we did a EUS guided liver biopsy, but now the indication is increasing EUS guided varicella coiling or glue or PPGM, or maybe in the future EUS guided portal system shunt. And now we are using contrast enhanced EUS and elastography, and we also do ablation for liver tumor. So this is my last slide. I think the field of endohepatology is expanding, and we can perform elastography, PPGM biopsy, liver biopsy for parenchymal diseases, and we can apply vascular intervention for portal vein hypertension. And now we can ablate the liver tumor. So there are so many procedures we can do in this area of endohepatology. Thank you for your kind attention.
Thank you, Dr. Nakai. Any question or comment? So, Nakai, your center, because I think there has been a concept changing between the endoscopy and in the hepatology field. So, like in your center and in Japan, so then how you collaborate with most Japanese hepatologists regarding this issue?
Thank you for your question. So I think in Japan still, so the difference in the US and the Japan is, in the US, hepatologists don't perform like liver biopsy. They ask radiologists to perform liver biopsy. So there's some hurdles. So they have to consult radiologists. But in Japan, they do liver biopsy and they do ablation. So they don't have to ask other doctors. So in Japan, still all the procedure performed by hepatologists, not endosonographer. So, but if there's a advantage of EUS guided hepatologic procedure, then we can change in the future.
Yeah, please, Prof.
Congratulations, Professor Nakai. I have a question that now the EUS guided tips information is available only in animal. So looking at the information in the animal, you think the chance to become true in the human is very high, intermediate, or very low level? What is the things that will prohibit this procedure to come to the human?
Thank you for a nice question. So I think there is a hurdle because if you go through the stomach or intestine, there's a risk of bacterial contamination, like causing bacteremia or sepsis. And also, there is no dedicated devices for EUS guided photo system shunt. So I think these two hurdles must be solved to come to the clinical application for EUS guided tips.
Any question? Any other question? Dr. Hara, you want to ask? Okay, then thank you, Dr. Nakai. So the next speaker, Professor Kazuo Hara, also very famous from Aichi Cancer Center in Nagoya. So the topic is also, I think, very, very important regarding the anatomy and diagnosis in endohepatology with EUS. Please, Professor Hara.
Yes, thank you, Chairman. Thank you for organized committee, and thank you for President Professor Sina and Dr. Omata. Okay. My topic is the liver anatomy and diagnosis with EUS. So from that, I just introduce the liver anatomy by my procedure. Okay, this is the COI. This is my colleagues. Thank you for my colleagues. So liver anatomy, so I recommend follow the vessel, follow the artery, and follow the portal vein. This is a very easy to understand the liver anatomy. So at first I mentioned from stomach view, and second from D1. So 2011, more than 10 years ago, I published a paper. This is a liver anatomy. I explained the liver anatomy in this paper. So I recommend following the artery and the portal vein because very easy to understand the segment. This is my imaginary in my mind from stomach. At first, I visualize celiac, and then counterclockwise rotation, I follow CHA, and more than counterclockwise and pullback scope, we can see the GDA and the PHA. And more pullback scope, clockwise rotation, right hepatic artery, and counterclockwise left hepatic artery. It's very simple. This is, in my mind, not real anatomy. This is a D1. At first, I visualize the celiac, and adjust, I follow the CHA, and clockwise rotation, we can see the GDA, and counterclockwise, we can see PHA. Pullback scope, left lobe and right lobe, we can see. And push and down scope, we can see the cystic artery and the anterior and the posterior. It's a very simple. I don't, it's simple, but for me, it's very simple. So this is a video. I follow the vessel from stomach. At first, I visualize aorta. This is aorta. This is celiac. And around here, we can see the left gastric artery around here. And I push and down, I follow CHA. This is a CHA. And counterclockwise rotation, pullback scope, I follow CHA. This is the pancreas. So around here, GDA, you can see this is the portal vein. Yes, this is GDA here, GDA. This is the right hepatic artery. This is the left hepatic artery. Left and right. Not so difficult, right. This is the portal vein. This is the left hepatic artery. This is the right hepatic artery. I follow right hepatic artery around the right hepatic hilum. This is a portal vein. This is anterior portal vein. And clockwise more. This is a, clockwise more. Please, clockwise more. Yes, this is a posterior portal vein. Posterior. From stomach. This is a posterior artery. This is a A7, A6. This is a posterior. Posterior. This is anterior. This is a posterior artery. This is a right anterior artery. This is a right hepatic artery. So this is from stomach. But not so difficult. Just clockwise, just follow the vessel. Very easy. This is a D1. I follow the vessel also from D1. So at first, this is a celiac. This is a CHA here. I follow the CHA like this. This is a portal vein. This is a CHA. And clockwise rotation, a little bit pullback scope. We can see, and here, GDA here. Yes, GDA. This is a proper hepatic artery. GDA here, GDA. Proper hepatic artery and the portal vein. This is a right hepatic artery. Here is a left hepatic artery. Here, yes, here. This is right and left. I follow the vessel up and down, slowly down and push. This is the posterior artery. This is the anterior artery. So quite simple. But if you want to puncture the bile duct, this method is not enough. Around here, counterclockwise rotation, we should visualize the basics, and we puncture the basics or something. So this method is just visualization. If you want to know the segment, this technique is enough. And if you want to visualize, so liver hepatic hilum, very easy to see by EUS. And left lobe also very easy to see. And segment 6 is very easy. But peripheral, the right side, sometimes segment 4, segment 7, 8, and segment 8, sometimes very difficult to see. So this is the case. This patient has a segment 2 cyst, very peripheral, segment 8, FNH, focal nodular hyperplasia, and the very peripheral segment 4 cyst, and segment 7 cyst. From now, I visualize all region. At first, from stomach. This is the left lobe, counterclockwise rotation. We can see the segment 2 cyst, very easy, because in the left lobe. From here, clockwise rotation, we follow the portal vein here, UP portion here, UP segment 2 cyst. This is P4, P4, segment 4 portal vein. A little bit clockwise rotation, we can see the cyst. You can see this is segment 4 cyst. Here also, segment 4 cyst. Very easy. So just follow to the portal vein. And here, clockwise rotation more. This is a middle hepatic vein and right portal vein. Stop. This is anterior portal vein. And P8 and P5 here. Okay, P8. So around here, I want to see the segment 8 tumor. But in this time, I cannot see the segment 8 tumor. But I will see this is a portal vein, the portal vein, posterior portal vein. This is a, can you see? This is a light, this is a light hepatic vein, clockwise rotation more. Yes, here. This is the segment 7 cyst from stomach. Not so special, just clockwise rotation. So very easy to visualize the right lobe from stomach. So same patient from D1. At first, hepatic portal vein here. Here, this is the left and right hepatic artery G gallbladder. From here, I follow the portal vein. This is the right portal vein. This is P8 here, P8 and P5. Around here, we can see some area. This is a FNH. Very unclear, but this is a region. And there I follow the posterior. You can see segment 7 cyst. This is a P7, P6, and the right hepatic vein here. And here is the segment 6. Very easy. So this is the right portal vein. Now I inject contrast medium, sonazoid. Can you see FNH? Like this. And finally, I want to see this region from stomach. So I put back scope slowly. This is from stomach. I will see this is a right portal vein. This is a right hepatic vein. Can you see here? This is FNH. Finally, we can detect the segment 8 FNH from stomach. So we can see almost all region from stomach. So stomach is very important. But this is a very far place. We cannot puncture. So if we want to puncture segment 8, D1 is better, of course. And the biliary tree, just visualization biliary tree is very easy from D1. Just visualize, no intervention, just visualize. This is the extrahepatic bile duct and the left hepatic vein. Left hepatic duct. This is a segment, this is a portal vein. This is a posterior. This is a anterior. Can you see? Anterior, posterior, the left. Portal vein, right hepatic artery, and the posterior artery and the anterior artery. Quite simple. So I mentioned again, this technique is just visualization for understand the anatomy. If you want to puncture or if you want to perform intervention, you need more clockwise rotation or something. So case. This case is a cystic duct tumor and liver segment 4 tumor, maybe metastasis. Can you see? Very small segment 4 and peripheral. This region is sometimes very difficult to see by EUS. And here is a cystic duct tumor. I suspect cystic duct tumor is a primary and metastasis to the segment 4. So at first, I insert scope from D2 and pull back scope. Now short position. This is a cystic duct tumor. Here is a CBD. I follow CBD, pull the scope here, and here is the left hepatic duct, and we can see the portal vein here. Around here is the segment 4. You can see segment 4 region. Now, balloon is too big because the probe in the duodenum. And I pull back scope too much. Now short position. Here the tumor. And from here, I puncture this region. This technique is most important. Sometimes segment 4 is very difficult to puncture, especially like this, very peripheral region. This is a needle, and I puncture this region. Okay, so another case, segment 8. This patient pancreatic cancer and liver metastasis segment 8. Maybe liver metastasis. From now, we check the segment 8 and puncture and get tissue. At first, from stomach. This is a light portal vein, segment 8, P8, P5. Okay. So P8 here, can you see? Segment 8 tumor, very easily. But very deeper portion and, this is a portal vein. So if you want to puncture, maybe a little bit difficult or dangerous. So next step is from D1. This is the pancreas. This is splenic vein and SMB and the portal vein here. And here's hepatic hyla. I follow the portal vein from here. This is a right, a left. This is a right. I follow the segment 8 portal vein here. This is 8. Here we can see the tumor very easily. This is a right hepatic vein. More clockwise rotation, we can see the right kidney segment. From now, I puncture the segment 8. Not so difficult. Very close from D1. Okay. This is my final video. So this is my message. EUS guided puncture for liver disease, liver mass. It's not so difficult. And from the stomach, we can see almost all the region in the liver. Almost, not perfect. So we can puncture multiple regions easily by EUS in a single session. Lymph node, or multiple metastasis, or ascites, or dissemination, or another tumor. Only one single session, we can puncture all region. So EUS is a nice compared to the practice. So why not? My message is, why not EUS FNB for liver tumors? Thank you for your kind attention.
Thank you, Professor Hara, for difficult presentation. It's not easy for me. Is there any questions or comments from the audience? Brother Chai?
Professor Hara,
Yeah.
just want to say thank you to you. Yeah, I agree with Professor Nagai that it's difficult.
Difficult?
Yeah, it's not easy. Yeah.
I don't know why
But
difficult.
yeah, but you make it easily understandable. Yeah, and I think you, on behalf of the endoscopists, speaking in the liver conference, telling that why not biopsy through the EUS from the EUS. Yes. Okay. Thank you very much. Thank you.
So, Professor Hara,
Yeah.
very nice lecture. So just one question. I know that sometimes as you mentioned, it's sometimes not easy to puncture in the special location, especially like segment 8 or 6. So in your center, you sometimes combine between percutaneous and EUS guided.
Yes, so in my center, at first, ES guided. Yeah, and if you failed, CT guided percutaneous biopsy. So ultrasound guided is not so effective compared to the EUS guided. Yeah, so CT guided is better. So, but almost, maybe nearly almost all region we can puncture by EUS.
Okay, thank you.
So Professor Hara, you also use, in the video you use, I think most of the video, puncture video is a Fujifilm EUS, but you also prefer forward viewing EUS. Is there any role for liver puncture for forward viewing EUS?
Yes, forward viewing EUS, so only special situation, segment 7. Segment 7 is very difficult, very far from the duodenum. So we can push too much the scope, and sometimes we can puncture the segment 7. But in this situation, it's very difficult, so I don't recommend. Yeah, so forward viewing scope is, and visualization is by forward viewing scope is a little bit difficult. So Fuji scope is better. This is my opinion.
Okay, Professor Hara, thank you for your great presentation.
Thank you very much.
So I will introduce the third speaker, Professor Sandeep Lakatakia. He's from the Zoom. Can you start the presentation? Hi, my friend.
Can you see my screen and my slide?
Yeah. Please start. Thank you.
At the outset, I would like to thank the organizers of APSL 2024 and my good friends on the dais, Professor Nakai, Professor Hara, and Professor Lishmana Rinaldi. So I'll be speaking on a next topic of EUS-guided interventions of varicose bleed. I know there are some other interventions of liver and portal system by subsequent speakers. I have no conflict of interest. We saw this slide when Professor Nakai was speaking, Endo Hepatology, where endoscope meets the liver. So I'll skip this and move forward. My main topic is EUS-guided varicose treatment. And normally, we have been doing endoscopy, forward-doing endoscopy, and targeting the varices in the fundus. But this requires expertise. And sometimes the blood flow is so torrential that we cannot visualize where the bleed is coming from. Our vision gets hampered, and then the outcome is poor, and the treatment is suboptimal. So the challenges that one faces with endoscopic glue injection using forward-wing endoscopy is obscured endoscopy view with blood, food, or even active bleeding. It's difficult to target the perforators, which are communicating the extragastric to the intragastric varices. It's inadequate to assess the complete obliteration. There's always a risk of rebleed because you will not know some of the varices are still left behind. And of course, the most serious one is the one highlighted in yellow, risk of embolization. As you can see on the video here. So the management of gastric varices has changed in recent times. Endoscopy glue is the current standard of care, but EUS is rapidly finding its place in these management. Why EUS for gastric varices management? It's an extension of endoscopy, less invasive than intervention radiology. You can see the anatomical details better. We saw Dr. Hara showing it so beautifully, all the liver segments and the pathology and the anatomy. I learned so much listening to him. We can target endoscopically the non-evident varices, the submucosal or even the wall varices. Perforators can be seen and targeted with lesser amount of glue. You can actually see real-time obliteration, and that's the best part of it. The only downside is the cost because you now use coil with or without glue. So the major advantages that EUS offers when we intervene for gastric varices using coil or glue or combination of both is that collaterals can be targeted, less amount of glue is required, and hence less risk of embolization. The downside is that embolization still can occur, but the risk is much, much lesser compared to endoscopy, a direct endoscopy glue injection. And sometimes in the beginning of the carrier, we may not be able to use the collaterals, which are the feeders. Coming to the technique of EUS guided gastric varices intervention, we generally position the EUS scope near the cardia and puncture through the diaphragm into the varices, the large big varices, and inject either glue or coil or both. First coil and then subsequently glue, so that the glue sticks within the scaffolding of the coils. Sometimes people use other material like gelatin foam for also using this kind of intervention. The coils are actually synthetic strands attached to the metal alloy coil body. And since they are larger in size, you can choose the diameter of the coil depending on the size of the varix. And the larger size is preferred compared to what is the variceal diameter to prevent embolization. Often, if the varix is large, sometimes multiple coils can be used. But the major advantage that coils offer is that reduced risk of embolization. These are several sizes of coils which are available currently. Addition of glue to the coil is that coils provide the scaffold where glue retains within the matrix, within the varix, and less volume of glue is required, which also then saves the needle, and you can do subsequent interventions if required. Let me show an example of this. These are large fundal varices, isolated, which has been punctured with a 19 gauge needle, and then through the hollow of the needle, the coils are being placed. The first coil is already gone inside, followed by the second coil. You can put Doppler in between and see whether the flow has reduced or completely obliterated. And then subsequently, we place some glue, which gives a more calcific appearance with acoustic shadowing, and the vision gets suboptimal. But nevertheless, this glue then stays within. You can cross-check with an endoscopy in the same patient as example shown here. This is a ball tip catheter to palpate the varix, and it's hard and firm and no blood in the lumen. So that can be a very gratifying experience. However, there are some adverse events reported by EUS guided interventions, predominantly only if glue is used. And hence, if large varices are there, then it is advisable to use coil first and then subsequently glue. The embolisms can occur in any circulation, and even thrombosis of the veins can occur. In one of the earlier publications, it was reported that about 47% of the patients, when only glue is used, has their embolism. But as you can see on the video on the right side, you see those blobs of glue, which is mixed with lipidol, is embolizing, seen on subsequent CT. But majority of these are asymptomatic. Nevertheless, one should try to avoid this embolism, even if they're small. And that's why coil is preferred along with the glue. What are the results of these procedures? The first publication came about 14 years back when EUS guided coils for gastric varices were reported by Romero Castro. These were small number of patients. The number of coils, average coils, are very high because they used smaller sizes varices, smaller sizes of coils. Subsequent publication few years later, also from the South American group, showed that using either coil versus only glue in the treatment of gastric varices, a multi-center study showed that both are quite effective. However, patients who had glue injection had a longer hospital stay compared to those who had coil injections. The mean number of endoscopy sessions were 1.4 overall. The complication rates, if you see in the right graph, is much higher with cyanoacrylate compared to those who used coil. So that's a major advantage, that using of coils reduces the adverse event, that's mainly embolism. Ken Binmoller and his group then published their experience of over 6 years of using this method of coil and glue. They had 151 patients with very high technical success. Of this, about 100 patients also had follow-up, and they could actually demonstrate that these varices which have been treated upfront continue to remain obliterated even for longer period of time. There was only one embolism in 151 cases. However, there were some cases of rebleed which could also be managed again with re-injection of coil and glue. The RCT on this aspect has come from Robles Medranda, also from South America, Ecuador, where he used coil plus glue versus coil alone. And this study of 30 patients in each arm shows that complete obliteration can be done in both arms. It is best 100% technical success with combination of coil and glue, and immediate varix disappearance was seen in patients where this combination was used. Whereas only coils, if you use, it takes longer time for it to thrombose, and it can occur after the procedure has been done. So coils take longer time to thrombose or occlude the varix, which has been addressed. But if you really want the complete job to be done, it is better to inject glue so that you can be safe and leave the patient like that. The cumulative incidence of reintervention also was seen much lesser in patients who had combined approach. Although gastric varix reappearance was seen in both the groups, much more in the coil alone arm versus coil plus glue. So this was a meta-analysis which came some time back using all different modalities for treatment of gastric varices. The hemostasis using any method is almost comparable. Obliteration, EUS is much, much better compared to endoscopic treatment, and coil glue was supposed to be the best. We also conducted a study, a randomized controlled trial comparing EUS-guided coil and glue versus endoscopic treatment of conventional treatment of endoscopic glue injection. My colleague Rajesh Gupta presented today morning in one of the forums in Apostle. So the aim was to look at the adverse event, the embolism in both the arms, and we had a CT scan done in these patients later on. The secondary outcomes were the efficacy of the two techniques, the rate of reintervention and rebleed rates. This is a chart of the results. We had to stop the study in between because the pulmonary embolism is equal in both arms, one in the coil glue arm and 3 patients in this. But it's a secondary outcomes which really made a difference. The complete obliteration of varix at 1 month was much higher in the coil and glue arm, the 93%. The overall rebleeding rate is almost 0 in these patients at 1 month and 3 months period of time. The reintervention rates also was much lesser in coil and glue compared to endoscopy. So in our unit, if the patient comes with a fundal varix or a gastric varices with bleed or large fundal varix which require a primary prophylaxis, now a trend is to go directly with EUS guided interventions. These were other collaborative publications from the international group, and this showed comparing same thing of glue versus with endoscopy versus EUS guided intervention. There were lower number of sessions with EUS guided intervention, less rebleeding episodes and lesser reinterventions. So net EUS guided therapy for gastric varices using coil and glue is safe with better efficacy, low bleeding rates on follow-up compared to conventional endoscopy group. What about primary prophylaxis? So far, we have been treating patients only those who bleed, but are we now, since we have made it safer, is it justified to address these large varices in the stomach using EUS-guided intervention? There are publications now, again from Ken Boehner's group, of 80 patients where they had very good results and no rebleed rates. A very recent publication this year in January from the EUS collaborative group of 10 centers have shown that not only technical success is 100%, the clinical success also is very high. And adverse event, both intra-procedural and post-procedure, are very, very less than 5% in the post-procedure and intra-procedural less than 2%, which is quite gratifying. And now it's looking more safer in several hands that who can do these procedures. The last publication which I'm addressing is again from the US group, where they have done a meta-analysis of all the publications, just came in EUS journal recently, that EUS-guided therapy for gastric varices is feasible and clinically successful in both primary and secondary prophylaxis of gastric varices. Can we do EUS-guided therapy for all? Maybe yes, but sometimes if the varices are plenty and carpeted, especially with portal hypertension because of portal vein thrombosis or splenic vein thrombosis, where it's all carpeted over, it's sometimes difficult to address them in one go. So how do you decide which method to use, EUS-guided intervention or endoscopic intervention? If the varices are high risk, large, and have bled recently or have red hemocystic spots, they are the ones to be used by EUS. They can also be considered for patients who have failed therapy with endoscopic conventional treatment, those who come with rebleed, or those are poor candidate for TIPS, for example, advanced decompensation not suitable for intervention radiology, hemodynamic instability, and limited IR experience. However, it's not available at all centers, and still conventional treatment is practiced at most centers and should be considered. If you're doing an endoscopy and you see a bleeding varices, there's no point changing the scope to EUS. You can directly address that bleeding and come back later with an EUS scope to see whether they've done a complete job. In the end, I would like to conclude by saying that EUS-guided gastric varices management is safe. You see it real-time obliteration, whether you use EUS-guided glue or coil or either of them. You can visualize and inject the perforators that reduces the requirement of the volume of glue or the coil, and there's a decreased risk of bleed. There's decreased risk of embolization using this method of coil and glue. In the end, I would like to thank you very much. Arigato.
Thank you for your great presentation, Sandeep. So is there any question from the audience? Pradam Chai.
Hi, Sandeep. How are you? I'm Pradam Chai. Hello.
Hi, Pradam.
Thanks very much for your nice lecture. I have a question that look like now in my idea. I think EUS guided coil or glue is better than endoscopy because we can see the real time and we can obliterate majority of the gastric varices. But how about the BRTO? Because actually the principle of the BRTO, they actually do the same, but they block the shunt from the splenic vein. So that's why they can kind of like do a big bombard with the tissue at thin or glue, whatever, and they don't care about the embolization. So because they block. But now with the EUS guided vascular treatment, I think that we can inject more, we can obliterate more because we have coil, which the incidence of the emboli is very low. So do you think that with the EUS guided coil placement plus glue placement, they will reduce the chance of the patient to go for the BRTO? What do you think?
Thank you, Pradam, for your comment and question. Yes, BRTO has been an excellent technique of blocking these varices. But for that, we need to have a shunt between the renal vein and these bunch of collaterals which are there in fundus. There are several exit points from these bunch, and it may be, so what they do is block the, for the people who do not know, they block the IRP team under fluoroscopic angiographic embolization. They first block the shunt with a balloon and then go beyond and then inject sclerosing agents in a liberal fashion. But if there are more exit points, then embolism still has a possibility. EUS has made it safer and simpler. If we use large size of coil, the coil has to be bigger than the varix diameter, at least 1.5 to 1.25 times the diameter. So if it's a diameter of the varix, the largest diameter is 12, use a 16 millimeter coil. The reason behind is that larger coil will then stay there and does not get embolized. If you use a 4 millimeter coil, there's always chance that it will embolize and cause more complications. These coils can also be, can go from one varix to the other, and you can perforate from one to other. And that will also prevent any kind of embolism of the coil. And the last part of adding glue to it actually adds more value. You can use the Doppler study real time and see that the lumen of the varix has been obliterated. We need more now head-to-head trials of doing BRTO versus EUS-guided interventions. And that will probably tell us which way the patient should be followed. In India, at least, most of these patients are under the care of gastroenterologists or hepatologists who are not quite convinced, whereas intervention radiology team has to be requested to do these procedures. And that's where, if we can do ourselves, we probably do not ask them and we can go ahead. We'll keep them as a backup to start off with. And I think hopefully we'll have more answers in some time to follow, which way we should practice.
Yes, please.
Okay, I have one more question. So, I mean, we know that coil is quite costly, quite expensive. So then can we block at the feeding vessel instead of the large vessel? then can we save a little bit of more money? And in your practice, you try to look for the feeding vessel all the time, and are you able to see them? And if you see them, you will try to block them only or go to the big gastric varices also, please. Thank you.
Yeah. Thank you, Pradham, for that question and comment again. So yes, whenever we do this EUS guided intervention, first we fill the fundus, especially the gastric varices in the fundus, to fill some water there, 100 or 150 cc, to distend the lumen, and then the varices are seen better. And if you spend some time carefully, you will see some feeders. These feeders are basically vascular channels which communicate between the intraluminal varices and the extraluminal varices. If those channels, which are lesser in size or smaller in caliber, can be attacked by a glue or a coil is preferable, again, a smaller size coil depending on the size of the channel, then that would prevent the inflow or the outflow from the varix towards the extra gastric side. And there can be more than one perforators or collaterals or these channels which need to be addressed. So real-time Doppler would help us finding out these bunch of varices which may have more than one collaterals can be addressed at the same time or in quick succession in a few days' time.
Yes, please.
Thank you for your great lecture. I thank you my name is Romero Castro. I thank you on behalf of my team for your nice mention of our works and the image of the Arakawa type 1 and type 2. The question with coils is another trick is to use the more length as possible, because with one coil you fill the perforating feeding vessel or the gastric varice itself using 200 millimeters length coils instead of shorter coils. This is one trick we use. Another question is, we have published that in spite of deploying several coils, if you inject contrast, the contrast flows through towards the gastrorenal shunt and up to the IVC. So the cyanoacrylate is less risky than endoscopy and direct injection, but the risk exists. As proof, the group of the Brazilian, we had 25% of pulmonary embolism with coil and cyanoacrylate, and 50% with endoscopic direct injection. So we use only coils. Thank you so much.
Thank you very much for your kind comment, Dr. Castro. And I'm glad that you are here, and I'm so happy that you are making a comment in this. You are the pioneer in this field, and so glad that you are here. And thanks for sharing the comment of using a longer coils for patients with flow, which is going towards the renal side or the IVC side. Thank you.
Another question about the cost. If the patient rebleed stay more longer in the hospital, the cost increases. So neurovascular radiologists don't think about cost. They use as many coils as they think is effective. Thank you so much.
Yeah, I would actually add to that, the cost of the treatment by EUS is much cheaper than IR, because the intervention radiology per se is more costlier. Their technical cost is more, and time and radiation also is much more, whereas we can do the entire procedure even without fluoroscopy or with limited fluoroscopy. In India, the coils are not very expensive. Each coil costs about $100 maximum.
Yeah, yes, more or less. Yes. Thank you so much.
Okay, thank you, Professor Sandeep, for your great presentation and your comments. Thank you so much. We will move on to the next speaker. Thanks so much. So the next speaker is Pradam Chai, Hong Kong. He will talk about EUS guided liver and the liver tumor biopsy.
So first of all, I'd like to thank the organizing committee of the APASO in Kyoto for inviting me to talk about the EUS guided liver and liver tumor biopsy. Actually, Professor Nakai already summarized in his slides, and no more information on that, but we're going to look in more detail about all the papers. So when we talk about the adequacy of the liver biopsy specimen, particularly from the liver parenchyma, we have definitions. From ASLD, 1.5 centimeter total specimen length and more than 11 portal tract. ESL, Royal College Physician of Pathologists, different definition just a little bit. So most commonly used abbreviation for EUS guided liver biopsy include CPT as a complete portal tract and TSL as a total specimen length. The liver biopsy can be done via the percutaneous route, transjugular route, and through the EUS guided liver biopsy. And most of the papers we've discussed about the liver parenchyma instead of liver mass. I think the problem about liver mass is about identification. Where is the lesion? Which today we have a nice lecture from Professor Hara, how to identify, where to identify. The biopsy from the liver mass doesn't cause much trouble. The imaging of this patient is very easy because close to the antrum and duodenal bowel. So in overall, if we compare between percutaneous liver biopsy, transjugular liver biopsy, and EUS guided liver biopsy, percutaneous liver biopsy is conventional, popular, and low cost. And if you want to use ultrasound guide or CT guide, it's possible. However, it relatively has higher complication rate, and it's mainly focused on the right liver lobe only. So the left lobe or the caudate lobe will be difficult. And also it causes pain because it's done through the skin. And then the transjugular liver biopsy, less pain, but and it can be used as a porthole monitoring to measure the porthole hypertension, to measure the pressure, hepatic venous pressure gradient, and it's suitable for high-risk patients who have low platelet number. However, the specimen that we obtain from transjugular liver biopsy relatively smaller and fragmented samples. For EUS guided liver biopsy, the advantage is that we can perform and sample from multiple sites, from the left lobe, from the right lobe, from whatever segment, and it's superior for identifying small lesions in terms of if you find from the percutaneous ultrasound, it will be more difficult. However, it also have the adverse event rate as well, but more importantly, it requires expertise, and you must have the experienced endosonographer in your center. So look at the EUS liver biopsy versus percutaneous and transjugular liver biopsy. In 2016, in one study, EUS guided liver biopsy from both liver lesions significantly provide more tissues in terms of TSL and CPT compared with percutaneous liver biopsy, and longer specimen length than transjugular liver biopsy, but similar complete portal tract. But this is a result of only one study. If we look at the meta-analysis and published in 2020, include 5 studies, 301 patients from EUS liver biopsy and 176 percutaneous liver biopsy and 179 transjugular liver biopsy. The conclusion is that no difference in biopsy adequacy or adverse event for EUS liver biopsy compared with percutaneous liver biopsy and transjugular liver biopsy. So looking at this meta-analysis in 2020 seems to be the same. And also the another meta-analysis in 2021, and in this meta-analysis, they focus only in EUS liver biopsy only, and recruit 23 studies from 1,326 patients. And the pool total specimen length and complete portal tract was 45 and 15.8 millimeter respectively. And in subgroup analysis, look like that the FNB proved to be better in terms of complete portal tract than FNA. And also FNB with slow pull or suction technique provide similar total specimen length in terms of FNB together. And slow pull technique was better in terms of the complete portal track. So now we know that FNB seemed to be better than FNA. And actually the analysis that compare between EUS guided liver biopsy versus else, mostly they're done by the EUS FNA. And regarding complication of the EUS guided liver biopsy from 23 study, 1,300 patients, and we found that 7 study included 179 reported no complication in any patient. And in 16 study with 1,147 patients, 9.7% experienced post-procedure complication, mostly abdominal pain in 100 patients with almost of the complication. Emergency visits only in 1% of the patient. Unfortunately, 1 death was reported in first 24 hours after the procedure, but unclear cause of death. And regarding uni versus bilobar EUS guided liver biopsy, because this is advantage over the percutaneous, because we can do the biopsy from the left lobe and also the right lobe. The agreement between left and right is look like okay, near perfect for steatosis, good for ballooning. However, moderate for lobular inflammation and moderate for fibrosis. But we have chance to sampling for both lobes of the liver. In 2023, which is last year, there was a good and interesting meta-analysis, because in this meta-analysis, they recruit only study that use the FNB needle for EUS guided liver biopsy. And 3 of recruit study are retrospective 1 and 2 are prospective randomized control trial ones. And this is the study that use only the FNB needle, which mostly use the Francine needle. And percutaneous liver and then compare with the percutaneous liver biopsy. In this meta-analysis, they found that overall diagnostic adequacy was not significantly different between percutaneous liver biopsy and EUS liver biopsy. And when the result analyzed only in observation and RCT, they were similar results in terms of diagnostic adequacy and then for about diagnostic accuracy, percutaneous liver biopsy has overall higher diagnostic accuracy than EUS guided liver biopsy. However, if they analyze only from randomized control trial, there was no significantly difference between this parameter. And how about the overall adverse event? Overall adverse event rate were not significantly different between percutaneous versus EUS guided liver biopsy, and the analysis is the same with the observational study and randomized control trial. And about the difference in complete portal tract, the mean number of complete portal tract was higher in percutaneous rather than EUS guided liver biopsy. And about the total specimen length, also statistically higher in percutaneous than EUS guided liver biopsy. So in this meta-analysis, which all the study recruited from EUS FNB needle, which is better than FNA needle. In terms of diagnostic adequacy, equal capacity for diagnostic and staging. In terms of accuracy, similar rate of accurate diagnosis between EUS guide versus percutaneous, and comparable adverse event from both methods. However, in specimen evaluation, look like that percutaneous liver biopsy typically use longer biopsy specimen a little bit better in terms of complete portal tract, which makes sense because when we do EUS guided liver biopsy, we get more fragmented than percutaneous liver biopsy. And when we look at this randomized control trial, which is just published in 2023, and now they compare only between FNB needle, Francine tip, but diameter of needle different, of 19 versus 22 gauge needle. They recruit 42 consecutive patients and average age is 51 and mainly for abnormal liver function test and prospectively random between 19 versus 22 gauge Francine tip and bilobar US liver biopsy with 1 pass, 3 actuation per lobes. And 19 gauge provide longer pre and post processing specimen compared to 22 gauge, and no significant difference in terms of adverse event, post procedure pain or discomfort between two sides of the needle. 19 gauge get a longer piece of the specimen. And these are not the randomized control trial, but published this year in 2024 in the EIO. The result is quite similar, comparing between 19 versus 22 gauge needle. It's retrospective analysis over 2 years, 52 patients, and 60% underwent 19 gauge biopsy, and increased aggregate length with 20 millimeter versus 15 millimeter. However, no significant difference in terms of diagnostic yield and fragmented rate. The 22 gauge seem to be higher. Adverse event rate, no significant difference as well. And this study published in 2023 in American Journal Gastroenterology. They compare between EUS guided liver biopsy versus percutaneous liver biopsy. You look at this study, this is a randomized control trial after meta-analysis published in EUS journal last year that includes 5 studies. And this compare between FNB needle versus percutaneous liver biopsy. It is a single center randomized control trial and use a 19 gauge fancy needle versus 16 gauge from the percutaneous needle. And the main outcome is to look at percentage of total specimen length at more than 20 millimeter and more than 11 complete portal tag. In the result, adequate sample obtained in 70% of EUS guided liver biopsy versus only 32% of percutaneous liver biopsy. However, for histological diagnosis, final diagnosis achieved in almost all cases. And in terms of specimen quality, EUS guided liver biopsy resulted in longer total specimen length, 23 versus 17. The P is about 0.01, but more sample fragmentation. The adverse event rate is about the same in both methods. So regarding the techniques of EUS guided liver biopsy, for EUS guided liver biopsy, the techniques can be dry control, dry heparin, or wet heparin suction. The dry control, the stylus was removed, and 20 cc of suction is applied using the vacuum. And this method utilized dry conditions similar to standard EUS FNB technique. With the dry heparin technique, the difference is that we flush the heparin 500 unit heparin per 10 cc to the needle until the droplets are seen at the existing of the needle tip, and then we flush with air, and then followed by the 20 cc suction sealing, similar to the dry control. And the wet heparin technique, the needle is plumbed with the heparin until the liquid droplet emerge from the exit of the needle. And then 2 cc of water is suctioned into the sealing before attaching the 20 cc vacuum sealing. So make the column of the needle plumbed with the heparin and full with the heparin while we do the procedure. So then, this is a study published in 2018. It's a prospective pilot comparison between wet and dry heparin suction. And you see that this we fill the heparin until we see the drop and apply the sealing, fill with the 2 cc of water with 20 cc suction. And look at the result. The complete portal tract from the wet heparin techniques is more than the dry heparin technique and the control, which is a dry suction technique. So look like that the wet suction technique is good. And also their study compare between single pass, 1 needle actuation versus single pass but 3 needle actuation technique for EUS guided liver biopsy specimen. This is a randomized control trial and published in 2021 in GIE. It's prospective trial with 40 patients. And the findings was that the 1.3 actuation yield more complete portal tag and longer specimen. As you see in this table, that mean aggregate specimen length in 3 accentuation have 4.0, and in 1 accentuation only 1.8. The significantly different, and also the number of the complete portal triad in 3 extrusion is better than in 1 extrusion. And the length of the longest piece not much different, between both. So the conclusion from this paper suggests 3 actuation for the techniques. And how about wet heparin versus wet saline? This is a retrospective review, and they found that the specimen adequacy is similar between both groups, and specimen length, the median specimen length and length of the longest piece were not significantly different, but the clotting is more frequent in wet saline group, and higher adequacy in wet heparin group for biopsy from both liver lobe. And procedure pain, lower immediate procedure pain reported in EUS guided versus percutaneous liver biopsy. And in the techniques, they have a dry section technique, and look like that now the wet heparin technique is the best. Recently, there was a reported of the modified wet heparin technique, but not much information for looking at that. In the liver mass, I think not much information on that, but we can use the standard technique. And I think the difficulty of the liver mass is to identify the lesion. We also published one study comparing between 20 versus 22 FNB needle with anti and retrovert, and we found no difference. But the 20 gauge needle get a longer piece of the tissue. So my conclusion about EUS guided liver biopsy. For the EUS FNB needle for liver parenchymal biopsy, look like that EUS guided liver biopsy is maybe equivocal or for volume of the specimen with a similar adverse event rates. But compared between FNB needle, 19 gauge provide more tissue than 22 gauge needle. So I'm sorry, this one is percutaneous liver biopsy get more tissue. This is on the opposite side. And for EUS guided liver parenchymal liver biopsy, the wet heparin suction seemed to be the best at this time. However, no much information to compare with the modified wet heparin technique. And EUS guided liver mass biopsy seemed to be the same with other organs. Difficulty is about identifying the lesion. And with that, thank you very much for your time. Thank you.
Thank you, Madam Chair, for your great presentation. Is there any question or comment from the audience? So you mentioned percutaneous liver biopsy has more specimen.
Yeah.
So which do you recommend in your center?
Okay. I think we have to titrate because even the percutaneous liver biopsy get longer piece of the specimen, higher number of the complete portal tract, but not much significant difference. But you have to titrate between pain through the skin. You have to titrate that you can get only one area from the liver, but whereas EUS guided liver biopsy, you can sampling from bilobar or even more than that. But certainly EUS guided liver biopsy, the patient in general, they pay more.
Okay, thank you. Any comments?
Please.
Thank you for your lecture. A question is the EUS guide liver biopsy is less stressing for the patient and for the doctor. So this is an issue that has to be into account because the stress of the patient who is performed percutaneous liver biopsy is much more than the sedated patient under the EUS guidance.
Yeah.
And a question about the adverse events with EUS guidance liver biopsy is we can act immediately in case of bleeding, injecting fibrin or thrombin or even coils. Have you experience in that field?
Oh, yes. So your question is about immediate bleeding after the EUS guided liver biopsy. So if we go in deep for the techniques, we kind of like slowly pull the liver back, and we do like a zigzags to stop the bleeding. And sometimes we can push the sheet, stop there for a little bit. And if the bleeding is still going on, we can see immediately, and we can use gel form to inject to stop the bleeding. So in that kind of term, I think that EUS-guided liver biopsy probably safer than the percutaneous liver biopsy. But looking all the information, look like the serious adverse event not much different between percutaneous versus the EUS-guided. And for the first question, can you repeat again?
Yes, the US guide procedure is less stressful for the patient.
You mean stressful
Yes.
more for the patient because it's being sedated and
Yes.
more invasive.
And for the doctor.
Yeah, I do agree. It's more invasive, yeah. But no pain because the patient sleep.
Yes.
Yeah. But after the procedure, sometimes the patient might feel some uncomfortable feeling, but not the immediate pain, unlike the percutaneous liver biopsy. Yeah. Thank you.
So much.
Okay, thank you, Madam Chair, for your
Thank you.
great presentation.
So final speaker, the Dr. Cosmas from Indonesia. He's a very famous person, so no need introduction. So his title is EUS-guided portal vein pressure gradient measurement. Please, let's start.
Thank you, Professor Hara and Professor Nakai. Good evening, dear colleague, ladies and gentlemen. So, my outline of my talks today regarding the portal hypertension and variceal bleeding, and mostly about the SVPG and the PPG, the portal pressure gradient measurement, the differences and similarities about these two techniques, and studies about the EUS guided portal pressure gradient measurement and the comparison study. So we know that in our clinical practice that the most common complication of the portal hypertension is the presence of the esophageal varices as well as gastric varices. And the varices, we have a high risk for bleeding when the portal pressure increase above the 12 mmHg. And we know that the increase of SVPG is an indirect measurement, still considered as a gold standard for the portal pressure measurement. So can worsen the hyperdynamic circulation as the patient will further develop a decompensated cirrhosis with complications such as variceal hemorrhage, ascites, and other things, and then also recurrent variceal hemorrhage in the late decompensation condition. So this kind of the standard endoscopic procedure that we used to perform every day in our clinical practice. And also that mostly we do give our patient the treatment to reduce the portal pressures. And we know that now there's been changing the concept that we start to use the carfentanil in term, despite the non-selective beta blocker, the standard old beta blocker, because carfentanil, based on most studies, seems to be better drugs. So portal hypertension, that the most important, then when we can detect the patient with the clinically significant portal hypertension, where the increased portal pressure of more than 10 mmHg, with a specific threshold in which esophageal varices and ascites may occur. So if we talk about the portal hypertension, of course, we not only talking or discuss about the liver cirrhosis, but we know that there are also many etiology in the prehepatic, intrahepatic, and post-hepatic condition. However, that the liver cirrhosis patient that where alteration in structural and functional of the liver itself could lead to endothelial dysfunction and increase vascular tone and resistance. So it will cause further for intrahepatic portal hypertension. So HVPG measurement is considered as a gold standard for the portal pressure assessment. And we know that how we can measure the HVPG. So usually the balloon tip central vein catheter, usually performed by interventional radiologists as well as the trained hepatologists, and you can insert it into the hepatic vein, and then we can measure the wedge hepatic vein pressure and as well as the free hepatic vein pressure. However, if we look here that this still considers indirect measurement because sometimes it's not really correlate with the liver condition. And as we can see here that this one study looking at how that hepatic vein pressure measurement can be normal even in some or several conditions such as like splenic vein thrombosis, portal vein thrombosis, congenital stenosis of portal vein, and other things. So we also need the accurate portal pressure because we know that in the risk stratification, looking for the esophageal varices development regarding or based on the grading of the HVPG level, we can predict whether there will be the presence of the esophageal varices as well as the predict whether it can be rupture or not. Even though that we know that now there have been many developments in the non-invasive methods or tests based also based on the new our current Baveno consensus. However, sometimes we know that the portal pressure is not always in line with the significant liver fibrosis. So how do we see between the EUS PPG and the HVPG? Of course, the similarities, both EUS guided portal pressure measurement and HVPG is an emerging method to provide safe and direct measurement of a portal pressure gradient. However, if you look the differences that when we do the EUS guided PPG, we puncture the portal vein pressure, so it can be considered as more accurate technique to see or to evaluate the portal pressure itself. So this is how to measure the portal pressure gradient using the novel device of Cook, that PPG measurement devices with modified 25 gauge FNA needle, compact manometer. Unfortunately, this manometer is not widely available, and still not commercially available. This is the study that they made previously with the compact novel device manometer from Cook. And they found that from 28 patients that it has excellent correlation with this kind of method and equipment with the clinical parameters of portal hypertension, including the presence of varices, portal hypertension, gastropathy, and even the thrombocytopenia. So studies about the portal pressure gradient as a new gold standard. You can see that looking at this study in 2017, that it has been shown that doing the EUS guided PPG showed that 90.9% are successfully diagnosed with having clinically significant portal hypertension. And this study also showed that there was excellent association between the portal pressure gradient and many clinical parameters, where the PPG level increased in those with high clinical evidence of cirrhosis, varices, portal hypertension, gastropathy, thrombocytopenia. So the limitation is because most studies are this study is a retrospective study design, a single center study with a relatively small cohort patient, and the patient didn't have simultaneous transjugular HVPG measurement. And patients with suspected cirrhosis did not have percutaneous liver biopsy. So we ourselves that we have been developed our technique innovation for the portal pressure gradient measurement, that we use the standard manometer for use, that usually used for the HVPG. So we just try to innovate and try to see that this result, and we found that the result is quite stable, yeah, among the first 10 patients. So now we use this method to do the EUS guided portal pressure gradient measurement. You can see here that we puncture the portal vein as well as the hepatic vein. And then we've doing the flush with the heparin and also the connect with the catheter to the standard manometer with also the pressure set here. So if we look at nowadays there have been study also to correlate the EUS guided portal pressure gradient measurement with the HVPG. That this prior study with even though in the porcine study, so it showed that the excellent correlation between the EUS guided portal pressure gradient measurement with the hepatic vein pressure gradient measurement. And also there was an excellent correlation between the EUS guided portal pressure gradient and the evaluation from the interventional radiologist approach at all pressure range. So I think this novel technique of EUS guided PPG measurement using a 25 gauge needle and compact manometer was shown to be feasible in the porcine model and has demonstrated excellent correlation with the standard transjugular method in a wide range of vascular pressure. However, there have been an issue in clinical practice regarding the training curriculum, even for the HVPG, and then when we try to correlate with the standard examination by the hepatologist through like transient elastography and then the OGD and also the endoscopic ultrasound training or EUS itself. And also that, of course, the skill and experience of the operator dependent also very important. However, the most important that we have to look at the impact in clinical practice, as we already heard that from all the previous speakers, that how that EUS can evaluate the liver anatomy and then also doing the intervention, the therapeutic intervention with patient with gastric varices, and also can do directly liver biopsy. So maybe in the future that it can be the first line approach in patient with liver cirrhosis. But of course that we have to see also the practice guideline and risk, benefit, and cost. Of course, it will back to depend on each country and centers all over the world. So I would just like to conclude that portal hypertension is still the cornerstone in the management of liver disease. Acute variceal bleeding is still the most feared complication due to portal hypertension in liver cirrhosis. And portal pressure measurement, I think, is still important in diagnosis as well as the management of complication in liver cirrhosis. I would like to invite all of you to APASL Single Topic Conference on portal hypertension in Bali, 12 to 13 October, as well as the APDW in late November, also in Bali. So I think my conclusion, last conclusion, that education is not the learning of the fact, but of course it's always the training of mind to think. However, that looking at all of this innovation, I think imagination is always more important than knowledge. So that I thank you.
Thank you, Dr. Cosmas. So, question or comment from audience? No? Okay, from me. So, what is the best puncture site? Hepatic vein and the portal vein from stomach, from D1, or best puncture site? Please explain me.
Thank you. So I do mostly in the stomach. I think it's mostly in a patient with chronic liver disease. It's easy. But I know there was a study that when they looked at the difficult position, or maybe because of the already advanced cirrhosis, and sometimes they try to avoid the collaterals, the vessels along the G junction. So one paper I think showed that they tried to puncture close to the duodenum and also the duodenum. And yeah, I think, but still mostly that we do in the stomach.
Thank you. So Professor Nagai mentioned he is afraid infectious sepsis or something because we punctured vessel. So very severe complications occur or not in this method?
In our case series, I think we've done almost that more than 20 or 30 patients for EUS guided portal pressure gradient measurement, and even we also has published that we do concurrently with endoscopic treatment. So no significant complications, including like infection, bleeding. Maybe in my experience once, but it's just because incidentally maybe the needle punctured the varices, the collateral. But it can be managed very easy, and I mean using Doppler, and then we just inject the cyanoacrylate through the varices, and no significant or major adverse event. And also until now, I never seen the patient I think maybe infection not significantly happen. I mean, one patient maybe has a fever, but not really have a big impact. I mean, and still most of patient they can do it. I mean, go for outpatient procedure unless that they undergo like a cyanoacrylate injection. So usually we observe within 1 day admission, hospital admission.
Thank you very much. Yes, please.
Thank you for your lecture. I think the risk of infection could be minimized with instillating povidone iodine in the working channel of the endoscope and give a short course of antibiotics. A question is, we present preliminary results with a study on morbid obesity patients referred to bariatric surgery. We performed EUS PPJ plus a EUS guide bilobar liver biopsy. And the results were that 28% of patients had portal hypertension without varices or collaterals or fibrosis in the liver. And the cause was the group of portal hypertension had significant more score of steatosis. Perhaps in the pandemic of fatty liver disease, this kind of procedure could be useful in detecting early reversible stages of portal hypertension. Do you think so?
Yeah, I think I agree with you. Yeah, especially I know that nowadays that we face many patients with fatty liver disease, so especially like obese patient and other things. So I think yeah, this should be the very good method. I agree with you, and how we can prevent the complications such as infection. Yeah. Thank you.
Okay, no comment? Okay, so thank you very much for the speaker. So from now, we close this session. Thank you very much.
Thank you very much, the lecturers and moderators.